Good morning. Um, my name is Shannon Dorenzo. I think most of you know me. I probably have a few handful of the interns I haven't met yet, but I am the PT Mock pharmacist. I cover both the outpatient clinic as well as the inpatient service. And Dr. Carney had asked me to do some pain management pearls with you guys this morning. Of course, as you all know, we could spend a lot of time talking about pain management and the different areas of pain that we work in. And I'm not going to focus on specific disease states. I'm really going to just do a general overview of pain and some of the clinical pearls and tidbits that I think are important when managing patients. And hope you guys will learn a little bit from this today. And if you have any questions, of course, I am not too savvy with this stuff, but I know that you have a chat that you can put some things in, and then we'll have some I was hoping to do this in person so we could use the whiteboard, but we're going to make the best of this and do some calculations in this presentation as well. So if everyone can hear me, we'll get started. So we're going to talk a little bit about pain assessment, treating the pain by the ladder. We'll do some med review, some conversion and calculations. I'll talk really super briefly about the new pain management order sets that you may be seeing in Epic, supportive care, and if I have time, I'm going to touch a little bit too on med error prevention. So just some pain 101. Pain is subjective. It's hard to treat and assess. It can result from an injury, an illness, or perhaps a procedure. Pain can definitely be associated with increased anxiety, and your threshold for pain can be lowered by lack of sleep, fear, and depression. And the word hurt is defined differently by everyone. So one of the most important things that we can do regarding pain management is adequate assessment. And of course, that can be extremely difficult, especially in your younger patients. And then, of course, everyone has a different perception of pain and can give different scores. If you ask 5 people, what their pain score is, you're going to probably get 5 different answers depending on the person. One thing I will go ahead and tell you, I'm not going to spend time really discussing like NICU or PICU type pain management. This is just going to be real general in just a general pediatric population. But we do have several different pain scales that are available. There's what we call the FACES scale or the Wong-Baker FACES scale. And these scales have all been validated in different age groups. But this one specifically has been validated even as low as 9 months. There's also the number scale, or what we call a visual analog scale. And then we have this, what we call the FLAC scale. And I'll go into more detail about that in a second. Obviously, too, vital signs and observations are super important when evaluating pain and assessing pain. And then reassessment is key. And I can't emphasize that enough. Oftentimes we'll just prescribe a specific pain regimen, and then we won't go back and look at all the information that's been provided to us by the nurses and the patient, looking back at those pain scores, looking to see if when we gave that pain medication, did their score go down or did it stay the same? Do their vital signs change? Did they ask the important questions to the patient? How did you feel about the last 24 hours? How is your pain control? So I think we need to, I know it takes time, and I know sometimes obviously we're all really busy, but I think reassessment is probably one of the most important things about pain management. So again, these are some examples of different scales. Of course, we have this visual analog scale, and sometimes that one's a little harder to use in the younger patients because, you just ask them, hey, what on a scale of 0 to 10, what's your pain? Maybe if you do show them a picture a little bit, it might be more helpful. But, of course, the FACES scale, there's different variations on this, but this is an example of that Wong-Baker scale, and it can be helpful in giving you that score. Of course, this one does 0 to 5, whereas a typical pain scale is going to be like 0 to 10. There's also this, what we call FLAC scale, and this is more of a behavioral observation scale. And so the FLACC stands for face, legs, activity, cry, and consolability. And so all of these are graded or scored 0 to 2. And so you can obviously go through each of these categories and give a number, and then give that total number, which is going to be like 0 to 10. So again, some other important points about pain management and assessment is looking at vital signs and just observing the patient, of course. We do know that you can have increased heart rate, blood pressure, and respiratory rate, and also increased O2 requirements. Also, obviously if the child is crying, that's a clear sign that they must be having some issues or having pain, and then their facial expressions, or just some general observations that you can look at. So what has been pounded in my head since pharmacy school is treating pain by what we call the ladder. And so I'm sure you guys have seen this along the way. And so this is an example. And of course, you hear a lot about this, especially in cancer pain management, but it can be utilized in other pain management as well. And basically, it's a stepwise approach to pain management. Starting out, just using non-opioids, plus or minus adjuvant therapies. I mean, as your pain gets worse or your complications get worse, going up that ladder and seeing what things you need to add or what things you need to change to make that overall pain management better. So going up to, the ladder for 2, whether you use an opioid plus or minus some kind of non-steroidal, or whether you use some kind of, something for like neuropathic pain, like gabapentin. And then as you go up the scale, your pain management needs to be more aggressive, and you may have to branch out to other agents as well. So this is just a good depiction of how we really should always use a stepwise approach, and looking at that mild, moderate, and severe pain, and what other things could be influencing that pain or could be causing that pain. So when we're deciding on what we're going to use for our pain management, we have some treatment choices to make. So of course, with your goals comes some, obviously talking to the patient and the family. We've got several different scenarios here. Like if we're dealing with someone who's just coming in for like a procedure or a surgical procedure, that pain's going to be different and managed and assessed different than someone who's coming in like with more chronic pain, like a sickle cell patient. And so you need to look at what your goals are. You want to control that pain. You want to try to prevent withdrawal. You want to stabilize their hemodynamics, and then also just help in general facilitate better care. And so, again, with those goals, like if you're having a sickle cell patient, their ideal pain score may never get to a 0. They would like to just be, at a 4. They feel like they live at a 9 or a 10, but they might just be happy to get to a 4 and feel like they can go home and manage this pain at home. Whereas someone who's, came in with a broken arm and had to have surgery, they're not used to having pain. So they might tell you, well, my pain's a 7. But they might not realize that 7 is the worst pain they've ever had. So getting to a 0 for them is an obtainable goal, excuse me. And then also just choosing your ideal agent. So if we're looking at just a short-term pain management, we want something that's going to have a rapid onset, a shorter duration of action, that has little accumulation, something that can be, easily titratable, have minimal side effects, and have easy dosage forms. So again, not thinking about in terms of critical care or PICU or NICU type pain management. But this is something that's, something that you're going to treat for just a short period of time, and then either the pain's going to completely go away, or you have someone who has a chronic pain issue, and you're just going to get that acute process under control for them to be able to go home and manage it on their own. So I wanted to really spend some time this morning too, is just going over some basics about some of the medications that we use. And I know you probably might think, wow, Shannon, I know how to use these medications. But you would be surprised how many questions we get about some of these things, and also what questions we get from the nurses. And so we'll kind of touch on some of those things and some of the questions that we get from you guys as well. So good old basic acetaminophen. Of course, most of you have this memorized, what the dose is. It's typically 10 to 15 mg per kg per dose. We usually dose that every 4 or up to every 6 hours. One thing to keep in mind is it does come in some different dosage forms, and depending on which patient population you're using it in, usually sort of steers you to what you're going to use. One thing I will caution you about is, of course, these are more examples of what some of the things that we have here at the hospital. There may be some different dosage forms out there in the community, but a general rule of thumb, a liquid Tylenol or acetaminophen comes usually 160 milligrams in 5 mils. That's pretty much a standard concentration. And then there's also, of course, the tablet sizes. 325 and 500 is going to be your tablet sizes that are most commonly seen. Obviously, there's also suppository options. We don't use these, in all the patients, but they can be used. Typically, I think we see this more used in fever. But there are different sizes available, but at the hospital, we just have the 120 and 650. That's why I wanted to highlight those. And so just kind of going over those in general before I skip to the famous IV product. Think about it when you're prescribing this, because we get lots of questions about converting one dosage form to another. So if you've got, your standard teenage patient, 15-year-old who can swallow pills, if you get close to that 325, or 500 milligram dose, or you can make a variation, maybe the dose is 650, so you can do 2 325s. Really strongly consider that in that patient. You don't have to do exactly 10 or 15. You can do somewhere in between. Because you'd be surprised how many times we get called in the pharmacy about, hey, this kid doesn't want to take liquid, they want tablets, can you convert this to a tablet for me? Well, if you have put in the exact mg per kg dose, and say, for example, your dose came out to 547 milligrams and you left it there, I can't convert that necessarily because I don't have a 547 milligram tablet. So I'm going to want to convert that to a 500 milligram tablet. So of course we do have some leeway with rounding, but just kind of think about that when you are prescribing these drugs. And I'll remind you again about that at the end, but just look at what your final number comes out to, and also consider how old your patient is and if they can swallow pills or liquid. Of course, the IV formulation of acetaminophen, while it is very attractive option for patients, it is definitely not readily available. We will sometimes get it in as for an emergency situation for a patient who cannot absolutely take anything by mouth or cannot have a suppository. Example of that would probably be one of my kids, like if they were in the pediatric ICU and we had no options and they were having extremely high fevers. So most of the time, that's when we see it used here at the hospital, is those situations. There's been some studies done looking at using the IV formulation post-op in patients for pain. But one of the biggest issues with this, I'll be perfectly honest, is the cost of the medication is super expensive. They have come out with a generic product, and I don't have that pricing information. Hoping that we might see some more usage of this in the future, but I can't promise anything right now, just because it is difficult to get and it's super expensive. Another thing that, of course, has been probably drilled in your head is the max dose per day of acetaminophen. This is a drug that we need to respect as far as the side effects. So generally, the max dose is 4,000 milligrams a day, or if you're thinking of terms of mg per kg, it's 75 mg per kg per day. Of course, acetaminophen is more appropriately used for mild to moderate pain. And most often, the moderate pain is when you're adding it to an opioid. And then again, consider rounding to tablet size in older patients due to the large volume of liquid. So same kind of thing with ibuprofen. You guys know this off the top of your head, I'm sure, 10 mgs per kg per dose, usually every 8 hours. Obviously, it comes in different dosage forms. The liquid is 100 milligrams per 5 mLs. And then we have the different tablet sizes, 200, 400, 600, and 800. There is actually IV formulation of ibuprofen. There's a couple of different formulations. One is used in PDA closing in neonates, so that's a completely different formulation. And then there's also an IV formulation of just ibuprofen for pain or fever. But that was a new thing for me. I had not actually seen that before. And so when I was doing some research for this talk, I actually discovered that. So definitely haven't seen that used in the hospital as of yet. The max dose, again, if we think about 10 mg per kg per dose, which would be 40 mg per kg per day, 2,400 milligrams is a pretty, you know, a good goal as far as with your older patients who can take the tablet sizes. You could do up to a max of 800 milligrams Q6 for 3,200 milligrams. But typically, if I'm giving 800 milligrams, I like to back off to like a Q8 hour schedule, just because, again, some of the side effects that can come along with ibuprofen usage. It's most often used in mild to moderate pain. And we prefer not to use it in infants less than 6 months of age. Occasionally we'll get orders in the ER in babies, and so we highly discourage that usage. It's just not a lot of information out there yet. I'm sure there's more to come in the future, but right now we generally don't like to use it in the smaller babies. And again, same kind of thing with acetaminophen. Consider rounding to the tablet size in older patients, just because it can be a large volume of liquid. And so like if you have a 50 kg patient, they're probably not going to want to take 500 milligrams of ibuprofen. That's 25 mils. Even though it does taste pretty good, just think about that when you're prescribing it, and it would be okay to round down. So for example, if you had a 50 kg patient and they did not want to take liquid, it's okay to do 400 milligrams. Even though you think, wow, that's not 10 mg per kg, you'd be surprised that 400 milligrams works really well. So just really strongly consider that in your older patients, to use the tablets when you can, instead of, having all these weird liquid volumes. Because I can tell you when they go home, mom and dad are probably not likely going to give them all this liquid ibuprofen. If they can swallow pills, they're probably going to have some over the counter ibuprofen and take a couple of those at a time. So ketorolac. Ketorolac is a drug that we used very often here in the Children's Hospital, especially in our sickle cell population, but you also can see it in post-op patients and some of the procedural pain areas. In general, the dose is 0.25 to 0.5 mg per kg per dose, Q6 hours. The dosage forms that are available are 30 milligram per 1 ml vial. There's also a 10 milligram tablet. We don't use the tablets very often, but they are available and can be utilized for pain management. The max dose per day of ketorolac, depending on what reference you look at, some will say 60 mg per day, some will say 120. And then for the oral, the max is 40 milligrams per day. In general, ketorolac is probably used more for moderate pain. I mean, it can be used for mild pain as a single agent, but you typically see it more for your moderate or severe pain issues, plus or minus an opioid. One thing that we are seeing, and before we went live with Epic, we did a lot of review of pain management, infectious disease, chemo, different order sets and treatment plans that were being shared through the Greenville system. And so we tried to make some compromises on some of these plans. One thing is the ketorolac, and some of you have already experienced this. When you order it in the plan, it gives you a hard stop of 15 milligrams. So that is something that we've been talking about and trying to wrap our heads around whether we want to continue that practice. If you feel strongly that your patient needs the 0.5 mg per kg up to the 30 milligram dose, let pharmacy know, let us know, and we can help you with that. We've been trying to evaluate some literature to see, is there a great difference between giving a max of 15 versus a max of 30? There has been some literature that shows that, 30 is not better than 15, but we want to look at it too in some of our specific patient populations like sickle cell and see what the literature is. Obviously, we know that there's side effects, from ketorolac, so we need to monitor that closely. I don't have to remind you about the Lewis-Blackman policy in the Practice Act about that because of the issues with the adverse events that ketorolac can have. So again, this is a drug that should be highly respected. It's a great drug. It needs to be utilized in patients, but it also needs to be closely respected and monitored. So naproxen is another agent that we can use, an oral agent for pain management. It is an alternative to like ibuprofen or acetaminophen. In general, the dose is about 5 to 10 mg per kg every 12 hours. You can do the lower doses up to every 8. And a lot of the female patients will utilize this, especially for their menstrual cramps. And so if you think about what they have available as an outpatient, they're going to probably have the OTC product, which most commonly is referred to as Aleve. That's one of the brand names of the OTC product, but naproxen is a great drug. It's also commonly utilized in some of your chronic like joint conditions like JIA. And so it comes in 250 milligram, 375 and 500 milligram tablets. And so that can be utilized. We will occasionally, especially in our sickle cell patients, if a patient does like using naproxen, we can switch that to that alternative versus the ibuprofen. And then again, the OTC product is available as a 220 milligram tablet. One thing I will go backwards, I don't like to do this, but I just thought about it with the ketorolac that I meant to mention, is that, we have that general practice here about doing 20 doses per month. So just always keep that in mind, when you're prescribing ketorolac. A lot of people have been taught that over the years, and that's a practice that we also like to utilize. So again, 20 doses per month with the ketorolac. So I'm sorry, I meant to say that when we were on that slide. So another oral option for pain management, and this is usually seen more with chronic pain, is celecoxib or Celebrex. It is an oral alternative for mild to moderate pain. Again, most often seen with chronic pain. So we do have several of our sickle cell patients, again, that are on this medication. And it does come in a variety of different tablet sizes and capsule sizes, such as 50, 100, 200, and 400. So again, more is not always better. So you can certainly try the lower doses first, but you can look at references as far as what the max dose would be for that particular patient population. So now skipping on to our opioids, and this is a combination product that I'm sure you guys feel like we kind of hand out as like water at the Children's Hospital, but it's hydrocodone acetaminophen, more commonly known as Lortab. There's other brand names you hear sometimes called Norco or Vicodin, but basically hydrocodone acetaminophen is the combination, obviously of hydrocodone, and that's what we dose off of is the hydrocodone component of the drug. So in typically 1.1 to 0.2 mg per kg per dose. You will notice a difference from Epic from Cerner is that in Cerner it was dosed in mils per kg, but Epic is definitely dosed in mgs per kg, which is probably more appropriate. So 0.1 to 0.2 mg per kg per dose of hydrocodone. The acetaminophen dose is going to vary based on the dosage form, but the tablet sizes that we have are going to have that 325 milligrams of acetaminophen in them. And then the liquid formulation is going to have the 325 milligrams in the total volume of 15 mils. So when you are dosing these, in the back of your mind, you have to remember that it does have the acetaminophen component in it. Most of the time, pretty much all of the time, that acetaminophen dose is not going to reach your max dose of acetaminophen. So that question comes up quite a bit. Because, for example, if you're using acetaminophen in combination on top of this drug, you do have to watch for that total acetaminophen dose. So this question comes up all the time. And so you do have to remember that when you are dosing these drugs. Um, Most of the time, this is going to be used for moderate pain. I mean, it could be used in mild pain, but most of the time, moderate pain. Um, and again, the dosage forms, of course, are weight based. And then we have the liquid formulation as well. Oftentimes, too, we get requests to switch one to the other. So we may have to do some tweaking and rounding with that. So you might often get phone calls about that if we can't make it work, come out exactly right, as far as a one-to-one conversion from liquid to tablet or vice versa. So you may get phone calls about that to, get permission to change a dose. But if we can round it within reason, we will try to do that. But again, I can't emphasize enough about watching that total acetaminophen dose per day. So oxycodone is again something that we commonly use here in the Children's Hospital for pain management, most likely in our sickle cell population, but you can see it sometimes in some of our other chronic conditions and some of our post-procedural or surgery patients. Um, the dose typically is zero point 0.1 to zero point 0.2 mg per kg. Again, it's most likely you're going to start at that lower dose range for patients, especially those that are narcotic naive. So the dosage forms that we have for the short acting products are the tablet or liquid. I won't go in, I was really of course, I know a lot of this stuff right off the top of my head, but as a good pharmacist, I went through and double checked and looked at new references as far as what's available for these products. And actually, the tablet, which of course we would not use in the Children's Hospital, the tablet actually comes up to now up to a 30 milligram short acting tablet. And of course, that is definitely geared more towards palliative care, adult oncology patients, that sort of thing. But it was interesting to see all the different tablet sizes that are available now, even in the short acting formulation. Again, the liquid comes as 5 milligram per mil and is a great option for patients, especially younger patients who cannot swallow tablets or can be given through the G tube. Definitely used more for moderate to severe pain and can be used in combination with acetaminophen. One of the most probably abused drugs out in the community is a drug called Percocet, which is a combination of oxycodone and acetaminophen that is commercially available. Um, and that's, again, it's not that it's a bad option for us to have here in the hospital, but what we have to be cautious of is that acetaminophen component. And so that is one reason we don't utilize that in the hospital. You can certainly prescribe oxycodone and acetaminophen in the same patient. But if your intent is it for it to be like the Percocet type product, we don't have that in the hospital anymore. Again, that was a safety feature so that you would be more cognizant of your acetaminophen dosing. But just keep that in mind that it is an option in the community. Again, it's one of those that we don't use very often, but it is an option if you were transitioning someone to that product as an outpatient. Again, with transitional or chronic pain management, you can consider long acting products. So, for example, if we had a patient on morphine or a hydromorphone PCA, and they were going to be transitioning to a long acting product, and they haven't done well with, say, for example, MS Contin, you could conceivably use OxyContin as a transitional medication, but I wouldn't recommend that in just your average patient. That would definitely be a conversation about, that transition and how that would be utilized. But again, the long acting formulation is definitely a chronic pain management issue and a long acting product in those patients that would meet that criteria. So good old morphine, of course, we commonly think of the IV dose being used, especially immediately post-op or, with a procedure or as someone comes in with a pain crisis. So in an opioid naive patient, I would usually recommend a 0.05 mg per kg dose. And then in someone who's tolerant, you could do a 0.1 to 0.2 milligram per kg dose. One thing to keep in mind with this is that we have to be careful how we go. Now, I will tell you that as a pharmacist, just to caution you, you also know that some people can tolerate more morphine. It doesn't mean that more is better. So, if you've got a 100 kg kid, and you could give them 100, 10 milligrams of morphine, you might want to take pause and think about that, especially if they're narcotic naive. You might want to think, hey, maybe we should give them 5 milligrams, or 4 milligrams. So that's okay to go under a little bit, if you're just a little bit, anxious about what that calculation dose is going to come out to be. Of course, we also can use the oral morphine, and our dose is zero point 0.2 to zero point 0.5 mg per kg. It comes again in different dosage forms. Obviously, the IV formulation, which you're used to seeing. You can do the IV bolus, which is it comes in like a carpoject or a vial that the nurses would utilize. Of course, we have the PCA option in patients, and then IV infusions, which is more used in palliative care or in a PICU type scenario, for pain and sedation. But that's not something you would see on the floor unless it was a kind of a unique situation, like a hospice situation. The tablets come in either short acting or sustained release. And so there's a variety of different tablet sizes. I didn't want to get into that because there are a lot of different ones, and we may not have all those options in the hospital. So, of course, you could ask those questions if you were trying to prescribe the tablet. Again, the MS Cotton or the morphine extended release or sustained release typically comes in 15 milligram increments, say like 15, 30, 45, 60. But there's also bigger sizes that you probably would never prescribe, but there are those options out there. And then the liquid formulation, there's different concentrations as well as a concentrated formula. Again, that would be utilized in like a hospice, probably patient versus just your regular old pain management situation. Morphine is utilized for more moderate to severe pain. And it's also used in combination with adjuvant meds such as, acetaminophen or ibuprofen or, ketorolac, depending on what your, what kind of patient pain management you have in front of you. And also, it can be used as you're transitioning a patient, obviously from like a PCA. You can use oral morphine. I think we more commonly see like oral oxycodone or hydrocodone, but you can utilize oral morphine, and we do have a couple of patients that do prefer that. Again, and then also your chronic pain management, the long acting products like the MS Cotton. And as we transition patients, we can, if they're able to swallow those pills, we can transition them to a long acting. One thing to keep in mind about these long acting products is that we have to be careful as we transition. We won't, it's probably not a good idea to give a 5 or 6 year old an MS Cotton pill. If they can't swallow the pill, then it's not a good option for that patient, because you do not want to chew a long acting tablet. Does not come out with a good outcome. So, we have to really consider that option only for those patients who are able to swallow pills. So just another little tidbit to keep in mind when you're considering that for a transitional medication. Hydromorphone, or Dilaudid, as we commonly refer to. The IV dose is significantly different than morphine. 0.015 mg per kg every 3 to 6 hours is the most common bolus dose that you will see. An oral dose ranges from 0.03 up to 0.08 mg per kg every 3 to 4 hours. So definitely different dosing, much more potent drug than morphine. Obviously you have to keep that in mind and double check those calculations when you're utilizing hydromorphone. Again, it does come in a variety of different dosage forms. You most commonly see here the bolus or PRN, short acting formulation, also the PCA option, and then again the hydromorphone infusions that you would see up in the PICU or in a palliative care situation. Tablets do come short acting. There are some sustained release products out there as well, and there are some liquid formulations on the market too. Obviously, hydromorphone is typically safe more for severe pain, and for those patients who have not done well with morphine. And so this is usually the backup plan for that. Again, it's used in combination with other adjuvant meds. And in chronic pain management, there are some options for that as well. But, again, this is going to be probably in older patients or different disease states that you would not likely be managing, but it can be used for chronic pain management. I do want to touch on just real quickly some other options that are out there. Fentanyl, again, is something that you're going to probably see mostly in your post-op, procedural type settings and ICU settings, but it definitely has its place in pain management, typically third line in severe pain management. We have run into a little loophole with that, with this transition, with our merger and some of the stewardship scenarios that we have. There's an actual opioid stewardship team that's been formed. And so they actually have taken away our option to do a fentanyl PCA. And so we do have a couple of patients that we utilize this for in our sickle cell population. And so we're going to rally to get it back because we have a patient currently on it and we've made it work, but it's not been an ideal scenario for the nurses and for charting. But fentanyl in general has been kind of one of those drugs that is typically reserved again as a third line option. Chronic and palliative care, pain management. Most of you probably have heard that there is a patch available for fentanyl. So that's something that can be utilized as well. There's some, just some glitches too with that patch. It's not as easy to titrate a patch, especially titrating down just because of the size and the micrograms per hour that the patch does provide. Also, you can have, if patients are having fevers, that can be, can cause some adverse events. It could cause like a sudden release of the drug. So there's some caveats to using those types of dosage forms. And the dosing for fentanyl, I didn't want to get into that in great detail because it definitely depends on what you're using it for. And then the other kind of thing about fentanyl is converting it is not as clear cut as others. I mean, there's definitely conversion tables and suggestions about, converting from IV or a patch or from morphine to a patch, but it's just not, there's more ranges. It's just not as clear cut and the math is a little bit more tricky, with converting, but it's definitely a great option for patients who, have not had success with morphine or hydromorphone, but it's just a little bit harder to manipulate and utilize in our pediatric patients. And it's also dosed in micrograms. So you always keep that in mind. It's not milligrams, it's micrograms. So that's super important. And then lastly, I just want to mention methadone. Methadone is a drug that you will see more in the Children's Hospital as that transition up in the PICU, when patients have been on pain and sedation for quite a while and they transition them to methadone to prevent withdrawal. But it can be used in chronic pain management. So it's not something that doesn't need to be forgotten about. We would occasionally use this in our sickle cell patients for chronic pain management. But in general, it is available oral and IV, as you've seen, as those transition patients from the PICU. The dose definitely depends on the indication of what you're using it for. But just wanted to mention it so that, just for completeness. So what I want to do right now for the next few minutes and try to get through some of these other slides that I have is, one of the things that comes up quite often is how do we convert, one thing to another? And that was one thing that Dr. Carney wanted me to review. And so I thought we could do some math today. So just kind of going over calculations and conversions. So, this is a very commonly used chart It's readily accessible in Lexicomp, and I can't emphasize that enough to use your references. You can utilize your pharmacist and utilize your references that you have available to you, like such as Lexicomp. So this is an example of an equal analgesic dosing chart and how you can convert your opioids. So we can utilize this chart when we're doing our calculations and converting from one thing to another, either within the same drug, like you're converting an IV formulation to an oral formulation, or you're converting, from say an IV morphine to an oral oxycodone. So this is a great tool to utilize. And then we also have our handy dandy calculator that's available in Lexicomp. And I don't know how many of you have actually, and I'm going to attempt to click into this. Let's see if I can make it work. All right. See if you guys can see this. So this is the opioid conversion calculator that's found in Lexicomp. And so it has, of course it has some disclaimers about converting, but this gives you a great tool, to say, let's say we're going to convert, and you can, and of course it has, I'm pointing at my screen, you can't see me pointing, but it has it in here as milligrams per day. But you can just do a simple calculation in here as well. Like if you're just trying to convert a dose, like not necessarily a whole day's worth of doses, like say if you wanted to convert, a 4 milligram dose of morphine IV to oxycodone PO. So you do that and it gives you the calculation. And so you can either do it just if you wanted a quick check for a dose to dose calculation, or if you want to do a cumulative dose over 24 hours, it's a great tool to use. So we'll get back to our slides. So I wanted to do just some simple conversions. And so I've got some of these here. And so if you want to, obviously I can't do this in person with you, which would have been a better scenario. But if you want to spend some time, a couple minutes, working through these conversions, and then we'll go over the answers. So if you want to take a few minutes to look at these, and then we will go over the answers that you get. So take a few minutes. Okay, I know I haven't given you a lot of time, but I know the time is winding down and you guys have to get back to work. So we'll just do some practice runs through this, and we can, and I'm happy to share, these slides with Whitney, and so that if y'all want to practice some more on these calculations. But if you guys want to speak up or however you want to do it, just let me know with the conversion. So we'll start with our first one. So morphine 5 milligrams IV equals how much morphine PO? Do you might have an answer?
15.
15 is correct. So 15 is your answer for this calculation. Okay. So what about oxycodone 10 to morphine IV?
Five.
5 is correct. So it's basically a 2-to-1 conversion. Okay. So morphine 4 IV to oxycodone.
8.
8 is correct. Now this one is, so like if you were doing this conversion, oxycodone doesn't come as an 8 milligram tablet. It comes as a liquid, but that would be 8 mils. So one thing you would consider in this type of conversion is going like to 7.5. So just an FYI, that would be one example of something that you might have to round a little bit. Okay, so hydromorphone, 0.4 milligrams to PO hydromorphone.
2.
2 is correct. So in general, this is 5 times. So the PO dose would be 5 times your IV dose if you were converting one to, hydromorphone IV to PO. And so here's the reverse. So your hydromorphone 4 milligrams oral would be how much of the IV?
Point eight.
0.8.
0.8. That is correct. Good job. Okay, so now I'll make it a little bit different. All right, so we've got Miss Sally Smith. She's our 15-year-old who is having some pain, and she's actually on scheduled pain medication of 4 milligrams Q 4 hours with 2 milligrams every 2 for breakthrough. She has consistently received 3 PRN morphine doses per day. So calculate for her an equivalent oxycodone dose and schedule. So I'll give you a couple minutes to look at this. Okay, I know that we need to get moving, so I'll just go ahead and so basically what you need to do is calculate, how much morphine they're getting in a 24-hour period, and then you can convert that to your oxycodone dose. So for this example, it came out to 60 milligrams of oxycodone. And so one thing to keep in mind is you don't have to do a one-to-one conversion necessarily, especially when you're doing IV to oral, because you may want to decrease that dose by about, anywhere from 10 to 15%, because it's going to be a little bit more long acting and stick around, of course, for the patient. So, but if you wanted to do one-to-one, you could do 10 milligrams every 4 hours, or you could back down to 10 milligrams every 6 hours. So again, here's another example. This is a PCA setting. So the patient has a sickle cell crisis and it's been managed with the PCA and Ketorolac. And so they're getting a milligram an hour of morphine with 0.3 milligrams every 20 minutes. He has pushed his button 27 times in the last 24 hours. So you can calculate an equivalent oxycodone dose for this patient as well. I'll give you a minute to look at that. Okay, we'll go ahead and move on. This was just an accident. I didn't mean for the calculation to come out so similar, but it did. So, in essence, you're getting 32.1 milligrams of morphine in a 24-hour period. So, just off the top of your head, if hey, morphine IV is like a 2-to-1 with oxycodone. So, like 10 of morphine, 20 of oxycodone, that kind of thing. If you know that quick calculation, but it's still a good idea to, sit down and do the math. So your total dose of oxycodone is 64.2, which of course that would be a little bit difficult to manage as far as, tablet sizes or liquid. So a reasonable dose would be like 10 milligrams. And again, you could do the Q4 hours or back down to every 6. So I like math. It's a lot of fun. And so you guys should practice. Just wanted to mention real quickly, of course, just be cognizant of the new order sets that are in Epic as far as pain management. And if you have any questions, and if you haven't had an opportunity to do one through an admission, don't hesitate to call us if you're seeing some, different things and you have questions about how it's built. We're happy to help with that and facilitate that ordering for you if we need to. Of course, if any of you have ever worked with me, I'm a big proponent of supportive care. And that's, obviously super important with pain management, making sure that, you have something on board for constipation, something that's needed for nausea, pruritus. Those of you who worked with me in the past also know that I am not a fan of IV Benadryl. So preferred oral agents for pruritus when possible. Respiratory depression, obviously we have to keep that in the back of our mind. And that is a very low percentage of patients will experience respiratory depression, but we do still have to have some naloxone available, especially for patients who are on like PCA. Also respiratory prophylaxis with albuterol. This is more commonly seen in our sickle cell population, again, because they're getting typically scheduled IV narcotics. And so we want to keep them away from acute chest syndrome. Okay. One thing I just want to kind of touch on, because this is another thing that's near and dear to my heart, is preventing med errors. So just kind of in general, always remember to order your meds in appropriate units. Again, like micrograms versus milligrams, most everything you're going to dose is going to be in milligrams. But in terms of weight base, looking at whether it's dosed, mixed per kg per dose, is super important, and to understand those appropriate units. And if you're going to be ordering something in milligrams versus milliliters, for example, just always know what the appropriate units should be for your dosing. Try to avoid verbal orders. I know that's another big push with Epic, is trying to avoid those verbal orders and for the physicians to put the orders in themselves. Obviously, in an emergency situation, you might have to give a verbal order, but try to avoid those verbal orders, because they certainly, things can be misunderstood in translation. No decimal points. Let's try to round things when we can. Of course, I mentioned before, like 7.5 milligrams of oxycodone, like that's not like a huge, and even hydrocodone comes 7.5 milligrams, 2.5 milligrams. But when I say decimal points, don't do like 0.82 or 0, those types of things. Try to avoid those decimal points. Obviously, in some cases you can't. And then always have leading zeros. So for example, 0.8 versus 0.8, try to always have that. And this is more, when you're actually handwriting prescriptions, which you don't do a lot of that anymore. So it shouldn't be an issue, but just always keep that in mind. Double checking weights. We have to do this quite often. Sometimes we get a larger, younger child in. So always double check that weight on that patient. Use your calculator. Yes, just like I mentioned, we know those conversions, and some of them we know off the top of your head, but use your calculator and always check your final dose. Again, for those opportunities to round something or to just make sure something makes sense, and try to avoid those decimal points when you can. And then of course, utilize your pharmacist. So just some final thoughts. I appreciate your time this morning. I know this is a lot of information. I tried not to go too quickly, but do not get comfortable with what you know. It's not a bad idea to double check yourself. I double check myself all the time. So yes, we want you to know doses. Super important to know doses, but it's okay to check yourself. Always okay to check yourself if you have a doubt. Respect the medications, but do not be afraid of them. That is one thing, I know that sometimes you're, not so sure about prescribing, some of these narcotics, but they're drugs that need to be utilized when they need to be utilized. So don't be afraid of them, but obviously have a healthy respect. Double check weights and calculations. Can't emphasize that enough. Also, not just for a plug for pharmacy, but also utilize the concierge pharmacy services when you can. This is a great service that we offer here at the hospital, and I know that you guys utilize it quite a bit, but just, think about that when you are discharging a patient, especially with pain meds. Number one, just to make sure that they get what they need. The last thing you want to do is to discharge somebody and then go out to their community pharmacy and not have the drug that they need. And whether that pharmacy is going to give you a call and let you know that, it's kind of up in the air. They may not, but you don't want the patient to be without their medications. Also, some things require prior authorization. That's a bad word in my vocabulary, but it happens all the time, and we want to know that before the patient goes home. And then of course, ask your pharmacist for help. Always, always, always. Like I always try to say, the dumbest question asked, or the dumbest question you have, is the one that's not asked. So if you have a question anytime during the day or night, we're open 24 hours a day. Ask your pharmacist for help if you need it. Thank you guys. If you have questions, you can email me or pop them in the chat, but I really appreciate your time this morning, and I hope this was a little bit worthwhile. Have a good day.
Thanks, Shannon.
Thank you.